living longer, living healthier, living better than ever before. Welcome to Mountain Pacific's Healthy Living for Life, a weekly series that gives you the information, education, and expert insight you need to become an active participant in today's ever-changing healthcare climate. Here now is today's program host.
Most of us experience some type of trauma in our lives, whether we recognize it as trauma or not, and we often experience it as children. These experiences can lead to serious health issues, including heart disease, cancer, diabetes, depression, and others. Welcome to Healthy Living for Life, a show dedicated to helping you do just that. I'm your host, Beth Brown. Today we're going to talk about trauma and its effects on health and healthcare. Stay with us. Joining us this morning is Dr. Reza Hosseini Gomi and Dr. Eric Arzubi, both with Frontier Psychiatry, to talk with us about trauma-informed care and how trauma affects health. And thank you so much, gentlemen, for being with us here this morning.
You're welcome.
So before I get started on a trauma-informed care topic, let's first talk about trauma and what exactly trauma is. Dr. Arzubi, could you explain to us what is trauma when we talk about trauma?
Sure. So if you would have asked this question about 20 or 30 years ago, the answer would have been something related to physical trauma, car accident, a fall, that sort of thing. That's what folks used to think about. What's nice is that that definition is sort of expanding, and I think that's a healthy thing, because trauma in the context of mental health, we consider sort of being exposed to toxic stress. There's, in particular, when people talk about trauma, we talk a lot about kind of exposing kids and children to traumatic events in childhood, and those sorts of things. There are a range of things. And so, for example, being exposed to physical or emotional abuse, sexual abuse, physical or emotional neglect, being in a household where there's a lot of challenges or dysfunction, where, let's say, there's a kind of parental separation, a family member with severe mental illness, a family member with a suicide attempt, a family member with severe substance use disorder. So really, when children are exposed or grow up in an environment where there's unpredictability and lack of structure, that over time sort of creates this toxic stress that then has a long-term impact on both physical and mental health. And that's often what we talk about when we discuss trauma. And mind you, trauma can certainly happen in adults. For example, soldiers who are deployed to Iraq, Afghanistan, will be exposed to combat trauma, both physical trauma as well as emotional trauma. Either they have a near-death experience or they have friends and fellow soldiers who die. And then, of course, having women who are unfortunately exposed to domestic violence or sexual assault, also another form of trauma. So that's the kind of stuff we're talking about. It's really things that are traumatic experiences to one's person and identity.
So you talked about trauma being something that can happen over time. On this show, we talk a lot about the difference between acute conditions and chronic conditions. Can you talk about trauma in the same way?
Absolutely. So, for example, a person who has, let's say, a motorcycle accident, that is one traumatic event, right? And so that's sort of a physical trauma. Let me kind of switch it now to sort of emotional trauma. Let's say, unfortunately this happens, but let's say a woman gets sexually assaulted one time. That one time is, enough to cause a lot of problems. We know that, and it's awful and toxic in every possible way. But that's one acute event versus, let's say, a child who grows up in a household where over the course of 5, 6, 7 years, there's emotional and physical neglect. So you can see they're different sort of traumatic experiences. One happens sort of over a long period of time, and sort of the ongoing impact of this emotional neglect and physical neglect versus kind of the one-time sexual assault event. They both have an impact on mental health outcomes and physical outcomes, but as you can see, the quality of the type of trauma is different.
So you've given us some examples. I think we understand what we're talking about a little bit better here. What about how prevalent trauma is? Do we have statistics about how often this actually happens to people?
Yeah, unfortunately, it's incredibly prevalent. The study that we often rely on is something called the ACEs study, which ACEs stands for Adverse Childhood Experiences. And in this study that was conducted in the late 90s, about 20,000 adults were surveyed. And what they did, what the researchers did was they said, okay, adults, tell us about your physical and your emotional health, and then tell us what happened to you when you were kids. And so they mapped these adverse childhood experiences against what the current health is of these adults. And they found that the greater the number of adverse childhood experiences that they survived in childhood reflected an increased risk for physical and mental health problems. And the number of adverse childhood experiences that were studied were 10, and they included, again, 5 forms of family challenges or dysfunction, 3 forms of abuse, and 2 forms of neglect. And in terms of the prevalence, they found that 2/3 of the population has at least one adverse childhood experience, and about 1 in 8 have 4 or more adverse childhood experiences.
Wow, okay. So let's talk about treatment options. We have about a minute or so left here. Dr. Gomi, I want you to jump in here if you can. Can you talk a little bit about some of the treatment options for folks who experience trauma?
Sure. And the mainstay of treatment is therapy, different types of talk therapy, including cognitive behavioral therapy and its variations, or psychodynamic therapy. There's a lot of different types of therapy, but the most important thing there is establishing rapport with the therapist, finding a therapist that you get along well with, you feel comfortable with, you trust. You know, we've moved past a point where we know now, given data, that you don't need to actually talk about the trauma. You don't need to. A lot of people are concerned coming into an appointment thinking that, oh my God, I have to talk about this horrible thing that happened. You really don't need to, and that actually is not necessary for the healing process to happen. What is important is you can do the therapy, which doesn't necessarily have to include bringing up the trauma itself, but how you're living your life now, the thoughts that you're having that are related to it are stemming from it, and then the behaviors that result and how to adjust those. So therapy is the mainstay. Now, of course, there are people that have incredible burdens of trauma that require also medications, and there's nothing to be ashamed of that. That's something that a medication is something we all need at some point in our life. And whether we're working with veterans with nightmares and flashbacks, whether we're working with youngsters with nightmares and really bad memories, or anyone in between, there are different medications. There are several that are relatively safe, that are okay to use long term. We really focus on using as low dose as possible and safer medications. It's tempting sometimes, if someone has a lot of trauma, to end up on a higher dose of a medication that's ultimately harder to come off of. So these are the kinds of things that are important to consider. Is therapy is the foundation, and then medication when you need it, relatively temporary.
Okay. All right. Thank you for that. We do need to pause here for a quick break, gentlemen, but we'll come right back, and we are going to talk about trauma-informed care next and how trauma is affecting how you may receive care. Stay with us. We'll be right back after these messages. Welcome back. We're talking with Dr. Arzoubi and Dr. Gomi this morning about trauma and trauma-informed care, and thanks for sticking around and continue to talk with us, gentlemen. So just like we did with trauma, let's start. Can we define trauma-informed care? What does that mean?
Sure. So trauma-informed care is really, I'd consider it sort of an umbrella term. It's really an approach. So there's no particular sort of intervention that you say, all right, that is a trauma-informed care, and there's kind of one intervention. It's sort of an approach. And so what does that mean? Well, so for example, if somebody presents with something like anxiety or depression, you know, there's some folks who have anxiety and depression without having had trauma, and some people who have anxiety or depression, but they've also had trauma. And a lot of times the trauma will make the anxiety or depression worse, or it might even be sort of the fundamental cause of the symptoms that are being experienced. So the point is, anxiety and depression happen for lots of different reasons. So if we can, in having conversations with the people we work with and care for, asking about past trauma really helps us understand that person better. In other words, I get a better sense of where, what's happening and why, and really can be more empathic if I can understand kind of where that person came from, right? So if there's anxiety related to sort of feeling, let's say somebody went to Afghanistan and served and was deployed for 8 months, and I know that they witnessed a lot of death and were near-death experiences. Well, now I understand kind of what the source of the anxiety is, right? And so when I have the conversations, I can validate, show that I understand, and that allows me to have a better connection with that person, and then be more effective. So again, trauma-informed care is sort of an umbrella term. It describes really an approach that shows validation and understanding of what that person has gone through. And then once you I think recognize that, then you can start throwing in sort of particular interventions, but always through that lens.
And you talked before the commercial break about children experiencing trauma, and I actually have a statistic in front of me here that 2 in every 3 children in this country say they've experienced some kind of trauma before the age of 16. So what kind of long-term effects can that have on someone who experienced that as a child but now is an adult?
Sure, so that carries over, right? So brain development happens, and Rez is the expert in brain development, so I don't want to get too far into the weeds, but brain development happens from before birth all the way until age 25, and there continues to be some development and growth and plasticity beyond that. But really, so conception to 25 is when things happen, and the fastest pace of brain development happens in the early years, sort of 0 to 3, 0 to 5, right? And so it makes sense, right? If you're building a brain, and you kind of have sort of toxic stress, or you have something bad happen to that growing brain early on, well, the impact is probably going to be higher on that brain and the brain development than if you had an impact sort of after the brain developed. I'm not saying you don't have an impact afterwards, but the point is you're more likely to cause long-term damage to brain development, emotional development, cognitive development, if you have this toxic stress early in the developmental phase of the brain rather than afterwards. And these things are long lasting. So we know from the ACEs study I mentioned earlier that, the likelihood of having anxiety, depression, suicidal thoughts, substance use disorders, and even physical illness goes up with every increase in the number of adverse childhood experiences.
And so you talked too a little bit about how having some idea of some trauma that someone may have gone through helps when providing care. Is there any element of risk that providers need to keep in mind when they're trying to treat somebody who has experienced a trauma that they need to be aware about? Are there risks there, I guess, that could affect that patient?
Well, for sure, right? I mean, there needs to be a certain amount of empathy and validation when even bringing up these issues. Now, people who don't feel comfortable talking about these issues probably shouldn't be bringing them up, because these are very sensitive and have an impact on the person you're talking to, right? But again, on the other hand, it doesn't have to be that complicated. For example, one of the things that was found during some of these long-term studies on trauma is that some people who developed obesity over time were actually that the obesity was actually linked to having had trauma early in life. And so one of the things we should consider, so let's say if you're a primary care physician or a surgeon working with a patient who is obese, instead of saying, instead of kind of automatically kind of making assumptions around, let's say, the obesity, for example, really asking more about the patient and what their life has been like, because again, then you might have a better understanding in terms of why the patient has the current health conditions and problems that they do, rather than saying, oh, that person's obese because it's a lack of exercise or bad diet. Well, it can be much deeper than that. And so if you as a clinician have an understanding that this person may have experienced some really terrible things in childhood, the questions become different, more nuanced, and actually probably more validating. And if you have a better relationship, you can have a better impact on outcomes.
Okay.
One interesting anecdote from the ACEs study went off of that topic, Eric, about obesity, is they found that there were reasons that they never anticipated, for example, with obesity being linked to those childhood adverse experiences. So one example, which was really striking, that stayed with me, was talking to patients who were obese later in life and saying, man, what was this connection to trauma? Or was there a connection at all? Or is it just totally a separate thing? And the explanations they received were things like, well, I used to be bullied a lot in school, but I noticed if I gained weight, they wouldn't bully me as much because I weighed more. It was safe, it was protective. I felt better, I felt calmer. And that's why a lot of times we've seen, this explains a lot why diets in the US don't work. People will lose weight. They almost 90+% will put it back on within a year. So, and why is that? Well, if you're losing weight, but that underlying trauma is not addressed, that weight loss is going to lead to anxiety, more reminders. Oh my God, I'm vulnerable now. People can, and then, so you're not addressing that. And then based on that, they started treating obesity with therapy for the trauma. Then they kept the weight off.
Wow, interesting.
So there's been some really interesting results.
Okay, great. Thank you for that. Unfortunately, we need to pause for another break. But when we come back, we're going to talk about how trauma might affect the care you get with a doctor, or if you or a loved one is in a nursing home. Stay with us. We'll be right back. Welcome back to Healthy Living for Life. We're talking with Dr. Eric Arzoubi and Dr. Reza Hosseini Gomi this morning about trauma-informed care. And now, gentlemen, I'd like to move in to let folks get an idea of what trauma-informed care might look like in different healthcare settings where maybe they are seeking care. So Dr. Gomi, if we can start with you, let's go into nursing homes and long-term care facilities. How might care look different to somebody who is receiving trauma-informed care in a long-term care facility?
It's a good question. And it does transition as you get older in age. And if you find yourself living in a long-term care facility, you're going to be in varying stages of needing assistance. You might be in a position where you need more physical assistance, but cognitively you're intact. In most of our facilities, of course, there's a component of cognitive impairment, and there's a whole range for that. And that's my background and specialty, is caring for those with neurodegeneration, cognitive decline over the years. And trauma-informed care really takes the form of needing informants, needing family members to inform our care. So as a provider, my staff of social workers and care managers and mental health specialists, everyone's a part of this. We obtain a lot of times information from the family members to let us know any relevant history about the patient. Things come up all the time. Recently I had a patient who was in a Japanese internment camp in the US in the 1940s. She's in her 90s. And this really informs how she responds and reacts to my care that I'm providing. So it's extremely relevant. So knowing that going in, I'm able to adjust how I approach her, be very careful about being too authoritarian, being too directive, and acknowledging that she really appreciates it, even though she does have dementia. These things really do have quite a big impact. And the further along the cognitive decline spectrum someone is, the harder the time they will have in telling you something clearly, like, oh, well, I'm getting angry right now because back when I was 10 years old, this happened. They may not be able to say that, but it really doesn't have to be too much detective work to figure that out. If someone is agitated or irritable, really as our job in long-term care facilities, I always ask myself, what's causing this? What we see, and again, time is very difficult. It's hard to have the staffing and the care, time needed to do this, but it goes a long way, and you can avoid a lot of extra medication, a lot of side effects, fall risk, things like that. So we really try to lower the medication burden, because it's tempting. There are medications that will, calm people down, and it's very tempting to use those. But trauma-informed care puts the focus more on using your words, and your actions to help diffuse the situation.
So would the approach be similar for someone who is seeking care from a primary care provider and not necessarily in a nursing home, or does it change there?
It depends on, when I see people in the office, I require that they bring someone with them, and it could be anybody. And I've had some people push back. I even had one person one time say, he was older, he was starting to have cognitive decline, said he just didn't have anyone, he was all alone. And then I kind of kept asked a few more questions, and I found out, well, he goes to the YMCA every day. And so he brought in someone he sees at the YMCA every day for the last 6 years. So usually you can find someone, because that person's going to have a good perspective, even if they're not good friends, even if they don't hang out outside there. If you've seen someone 5 days a week for 6 years, you get a handle on, how they are. So having that informant. So for primary care, you can encourage your front desk staff or your schedulers to say, hey, can you please bring someone with you? Try not to show up alone, because that can really help make that conversation go more smoothly. And that helps you get more information. Because, primary care doesn't have time to necessarily sit down. We have more time to go through some of this. So for them, it might be a more targeted question like, hey, I want to do the best I can helping you. Tell me, please, let me know if, and it might be to the caregiver, let me know if there's some way I need to approach you or the patient to make this easier. And they'll tell you right away. I've had family members come, oh yeah, just so you know, this happened, or they have always been reactive. Even if it wasn't the trauma, they tell you, they don't take this kind of thing well, so please try to approach it a different way. That makes a huge difference.
So is it the provider, either in a primary care setting or whatever setting, nursing home, is the provider the one who always starts the conversation, or can a patient, resident, or the person who comes along be the one to say, hey, here's what you should know, and how do they go about starting that conversation if they should or can?
Absolutely, and I encourage people. As part of our talks that we've been giving, we have some checklists and some preparation sheets, some informational things to give to even to patients and caregivers so that they know how to approach, and to give them a more empowered stance, a more proactive stance. Oftentimes when you're going to see a new provider, it can be intimidating. You sort of sit back, the provider's in the driver's seat. And really what works best is when you both take a proactive stance. So to that end, I tell patients and caregivers, family members, loved ones, to go right in and take charge and say, hey, let me set this up for you. Let me give you some background. Let me let you know about some of these background issues that inform how my loved one responds to things. Those are all appropriate things to do. And I encourage people not to be too shy to do that.
Good, perfect. We're almost out of time. I want to give you each an opportunity. One closing thought that you want to make sure we hear this morning. What would you say? Dr. Arzubi?
Yeah, sure. I think, like was suggested earlier in our conversation, this is something that's everywhere. It's not something that just happens to sort of other people. Everyone's affected in one way. So either, like we suggested before, 2/3 of people are exposed to this, or everybody at least knows someone who struggled with one of these things.
Okay, great. Thank you. Dr. Gomi, closing thought.
Just briefly, encouraging anyone that comes across someone older, and especially in a long-term care facility, and as soon as you see them being upset or agitated, ask yourself what might be underlying that.
Perfect. Gentlemen, thank you so much. Really interesting information. We appreciate your time and expertise this morning.
Thank you very much.
Thank you. And thank you so much for tuning in. We hope you'll come back and see us again next weekend. Until then, stay fit, stay well, and stay healthy for life with Healthy Living for Life. Have a great week, everybody.
Healthy Living for Life is brought to you by Mountain Pacific Quality Health in partnership with AARP Montana. We'd love to hear from you. If you have suggestions for future programs, visit our website at mpqhf.org or call us at 406-443-4020. You can also catch us on YouTube by visiting our website and clicking on the Healthy Living for Life logo. Production facilities provided by Video Express Productions.